Alan Grodzinsky in Department of Biological Engineering at MIT, along with mechanical and electrical engineering as well. And I've been here for quite a while, and the research that we're very interested in has been brewing for a long time, ever since I did a sabbatical at Children's Hospital in Boston in the Department of Orthopedic Surgery quite a while back. But then over the years, our research has evolved into problems that people face in orthopedics, namely the disease of osteoarthritis, which is a worldwide problem. The estimates, in fact, range from about 100 million to 600 million people worldwide. Tremendous burden. Pain and disability, of course, is a problem, as well as absence from work. So it's an incredibly difficult problem. One of the many facets of osteoarthritis, the issue that makes it a very difficult disease, is that it's not just one disease. It's really a disease that has almost 10 subfamilies of different kinds of patients and populations. One of them happens to be a disease involving very young people. Some folks who think about osteoarthritis typically think of it as an old age disease, but young people who injure their joints in high school and college or even younger, playing soccer or basketball, wind up very much at risk to developing osteoarthritis. So this is part of the aspect of the disease that we've been very interested in and concerned about. What happens when, in fact, it's almost an epidemic now amongst young girls and women in high school and college who tear their ACL, anterior cruciate ligament, and even if they do not damage their cartilage, ultimately the combination of injury and the inflammation that accompanies the injury can lead to long-term disability and the development of osteoarthritis even by age 25 or 30. So it's not just an old age disease, it's really becoming a disease of almost all ages. The disease of osteoarthritis is actually quite different than rheumatoid arthritis. So there are a class of rheumatic diseases that are autoimmune diseases, and the risk factors for those involve, of course, genetics as well as other issues. But these autoimmune diseases are most often systemic diseases, so there could be multiple involvement of different joints in the body. Osteoarthritis, on the other hand, is not an autoimmune disease, and there are many different risk factors for osteoarthritis. One is just how your joints happen to be aligned. So if you're moving your knee and you're lucky, there's perfect alignment, but some people are born with alignments of their knees and hips that aren't perfect, and over time there may be damage to the cartilage. In addition, these days the problems of obesity are adding to the risk factors. So people having obesity, of course, adds weight to the joint, but it turns out that's not the only issue. Fat tissue also has inflammatory cytokines within the tissue called adipokines, and those can add to the burden of the disease by inducing local problems. So osteoarthritis is most often a focal disease. If you injure one part of your knee, you might get osteoarthritis there and nowhere else in the body, whereas rheumatoid arthritis is a much more widespread, focused, non-focused. Turns out that there are no disease-modifying drugs for osteoarthritis now that have either worked or passed FDA approval. There are painkillers. You can take an Advil or Aleve for acute pain, and that might help in the very short term. But those are not what are called disease-modifying drugs, or DMODs. And the search for DMODs has been going on for decades. There are several potential DMOD drugs that have been tried by the pharmaceutical industry, and they have all failed for one reason or another. One of the important issues, though, is delivery. The old, if you would like to call it, old business model for a drug would be taking a pill every day. And it turns out that taking a pill every day is really a systemic treatment for what really is a local problem that you might have in just one particular joint. And so the trials in the past, and this is a decade or two ago, sometimes failed because of systemic side effects that had nothing to do with the efficacy of the drug in the region of interest. So just as an example, if the target was cartilage in the knee, and you took an inhibitor of an enzyme, like a metalloprotease, and that was taken with a tablet or a pill, you might develop, and that's what happened in published clinical trials that failed, diseases where frozen shoulder would occur even though the test was for knee osteoarthritis. And that's because of other problems that that particular drug might induce. So the issue of delivery is now being recognized as a very interesting and crucially important aspect of treating osteoarthritis. Can you target a drug to not only the joint, but to the tissue in the joint that you would like? So we've been very interested in delivery to cartilage. While cartilage is certainly one of several important tissues in a knee joint, for example, or a hip joint, and all of the other tissues must be accounted for, the bottom line in osteoarthritis is the degradation of cartilage, bone wearing on bone in the joint, and that being very painful. So we've been particularly interested in targeting drugs that might be efficacious to the cartilage itself. And that brings up an extraordinarily interesting range of problems and challenges of how you get a drug into this very dense tissue called cartilage.